Hi everyone, welcome to CADIO's webinar series. So good to have you here today. We are really excited to be joined today by Dr. Liz Lockhart. Dr. Lockhart is an assistant scientist in the Center for Health Policy and Health Services Research at Henry Ford Health in Detroit, Michigan. Her research area of interest include HIV prevention and care, social determinants of health, and implementation science in health systems. Dr. Lockhart received her first NIH funding for this project and will be presenting on her study, Most PrEP. So Dr. Lockhart, thank you so much for being here with us today, and we're so excited to hear you talk.
Yeah, thanks for having me. I'm going to share my screen. Okay, if anyone has any, I think it's come through now. So I'm going to talk today about our project here, which is called Most PrEP. It's a multi-level health system study to increase PrEP, which is pre-exposure prophylaxis for HIV prevention in primary care. Okay, so in the US, just to kind of get everyone on the same playing field, HIV is somewhat would be considered now a chronic condition. There's roughly about 1.2 million people living with HIV in the US, and HIV incidence rates have held roughly the same for the past 10 to 12 years or so. Roughly 35 to 40,000 people each year are newly diagnosed with HIV. However, like many diseases and illnesses in the US, there are vast disparities in who is acquiring HIV. So this graphic is a nice representation just to show that almost 70% of all new HIV infections in the US occur amongst both Black and African American individuals as well as Hispanic individuals. But this graph I like to show because it really shows those disparities and how they really play out. So as we can see here, 40% of new cases of HIV occur amongst Black or African American individuals. However, that population makes up only 12% of the US population. And as you can see here, the same holds true for Hispanic individuals, who make up roughly 30% of new HIV cases, but only about 18% of the US population. So Henry Ford Health is located in Detroit, Michigan, which is in Wayne County. And in this county in 2021, which is the year that the most recent data were available, there are about 7,200 people living with HIV, and about 250 people were newly diagnosed. Similar to the US, there are some vast disparities in who is being diagnosed with HIV in our county. About 80% or so are amongst men, about 78 to 80% or so amongst Black Americans as well as Hispanic individuals. And then in our county, we have a pretty normal distribution, if you will, of HIV diagnoses amongst age groups. But this graph here I like to show because it really shows in our county in particular how disparate the HIV rates are. So as we can see here in Wayne County, the rate of new diagnoses per 100,000 individuals is 17, and then you can see compared to the state of Michigan, the region in the Midwest, as well as the United States, we are vastly outpacing those other areas. So the federal government in 2018 designated a new program called Ending the HIV Epidemic. And what this program does is really highlights areas that have high HIV incidence in the United States, that can include both counties and states, and it really tries to focus prevention efforts in those areas. And so we're located here in Southeast Michigan, and we are deemed a priority county by the federal government. So there are ways that we have that are effective to prevent HIV. So kind of starting back in the 1980s when HIV was first discovered, there we have prevention efforts that were developed as of then, including condoms, not sharing needles, and abstinence with regards to sex. And then there's been really kind of a long period of time where those were the only prevention methods. However, in 2012, there's been some new biomedical developments that have occurred. So in 2012, a new daily pill called Truvada was developed for prevention of HIV. And this pill could be taken by both men and women, or males and females at birth, for HIV prevention. In 2019, a second pill option was developed and brought to market, and this was primarily for people who were not assigned female at birth. And then in 2021, an injectable method was developed, and what that basically means is a shot, and that people could take it every 2 months, coming into their provider's office and get the shot for HIV prevention. So I like to kind of say sometimes, great. So we know that HIV has been around for a long time now. We've got these prevention methods, mission accomplished, right? Well, not so much. So that led me to kind of think about, okay, what's going on? Why? So prescription rates for PrEP for those 3 methods I just mentioned have been fairly low. So as we can see here in the last 4 years or so, prescription rates for PrEP have been increasing, particularly among people who would most benefit. But like HIV incidence, there are vast disparities in who is being prescribed PrEP. So as you can see here, for males assigned at birth, almost 41% of individuals have been prescribed PrEP amongst those who could benefit. However, only 15% of females have been prescribed PrEP amongst those who could benefit. And really tellingly, there are some really vast disparities based on race. So white individuals who could benefit from PrEP, almost 95% of those individuals have been prescribed PrEP. And as we can see here down below on the green line, only 24% of Hispanic individuals who could benefit from PrEP have been prescribed it, and 13% of Black and African American individuals who could benefit have been prescribed. So here where we're located, as of 2021, there were only 262 primary care patients who were prescribed PrEP. There are other areas within our system, namely infectious disease, where people can go to get PrEP, but I'll get into some of the barriers or some of the issues with that a little bit later on. So only 262 patients were prescribed PrEP in primary care out of approximately 2,000 people who met the indications for PrEP. So as I kind of alluded to, why focus on primary care? In our system, individuals could be referred from their primary care provider to infectious disease. However, that provides a lot of barriers for individuals, because the way that our system and geographically is located is we are in the city of Detroit, and that is where the infectious disease clinic is located. However, our primary care clinics are located all throughout the Metro Detroit area. So for a person who is not in the city, getting a referral from their primary care provider could provide some barriers with regards to transportation, just making an additional appointment. There's the stigma of going to an infectious disease clinic. And so we really wanted to focus on where people were getting their care on a potentially yearly basis or a regular basis, as the literature and as most people tend to see their primary care provider at least once a year. Also, the primary care system is kind of the entry for people into the healthcare system. So it is a nice kind of area for people to, to be able to discuss these types of things with their provider. In our system, we see roughly 200,000 individuals in primary care per year. And so we have a large patient population of whom we can interact with and potentially have PrEP become an available option for them. So when I dove into the literature to try to understand kind of what the barriers to people having access to PrEP were, it became pretty apparent pretty quickly that the barriers were not just on one level, if you will. So it's not just that individuals are having issues with getting PrEP patients, or it's not just that providers are facing barriers to prescribing PrEP. There really was kind of this interaction amongst multiple levels within our system and within what the literature shows in general. I'll get into that a little bit more in a second. And then when I started to think about, what was going to be the best way to address this issue, so just full disclosure, I was part of the cohort, I think in March of 2022, taking the most training. And to me, it was kind of a no-brainer that, we know that the literature shows that there are multiple barriers for individuals to accessing PrEP. We don't know exactly what is driving those barriers or what is driving that access to PrEP. So why not figure out if there are certain components that we can either identify alone or in combination that are most effective at addressing those barriers to increasing access. And so what those provider barriers that the literature shows are is that one is that providers primary care providers, in particular, have low PrEP knowledge and awareness. PrEP, as I said, has been around for about 12 years or so at this point, but primary care providers tend to not really know about PrEP. This is what's been shown in the literature anecdotally in the development of this project and talking with primary providers and our system. We've found that there are, out of 180 or so providers in our system, there's about 3 to 5 primary care providers that feel comfortable prescribing PrEP, and the rest either do not or refer patients to infectious disease. Another barrier that providers face is that they feel uncomfortable discussing their sexual health with their patients. It might seem a little weird, right? Like, you're going to your doctor, your doctor I think many people assume that their doctors have been trained to discuss health aspects, but with their patients, but oftentimes primary care providers say that they don't feel comfortable discussing sexual health with their patients. And then there's also, with PrEP, there's some lab testing that needs to occur prior to when an individual can start PrEP. And so oftentimes providers will say that that is a reason why they don't feel comfortable prescribing PrEP. We don't really know if that is a true barrier, or if that's just kind of an excuse, if you will. But there are these kind of lab tests that need to be run prior to initiating PrEP. And then once a person is on PrEP, then there are some kind of residual follow-up testing that needs to be done. But it's not, in talking with providers here who are prescribing PrEP, it's not anything that is out of the ordinary in terms of ordering tests and that type of thing. And then the other thing that the literature has really shown is that there is this idea of a purview paradox, so that oftentimes primary care providers will think or say that infectious disease should be the ones who are prescribing PrEP to patients. And then infectious disease providers, when asked, say that no, it's primary care who should be prescribing PrEP. And so oftentimes it's kind of this limbo of the providers are saying, well, it's this other group of people that should be prescribing, and then it results in nobody really doing it. And then patient barriers that we've identified in the literature, again, even though PrEP has been around for 12 years, there's pretty low knowledge of PrEP. And by knowledge of PrEP, that can mean anything from just not knowing that PrEP exists to having misconceptions about who PrEP is for. So there's been an increase in advertisements on TV. There's been an increase in people hearing about it, but not necessarily thinking it's for them. So oftentimes the advertisements that are on TV that are done by pharmaceutical companies will highlight specific groups of people. And so that often, what the research is saying and what we've started to see as well, is that people think, well, I see that there tends to be what looks like, for example, gay couples on TV, so it's not for me. And so there's kind of the knowledge of PrEP is not necessarily as high as we'd like it to be. And then also somewhat concerningly is that oftentimes people have an inaccurate perception of their HIV risk. And so this is particularly true for a lot of different groups of individuals. And so they may think that, well, I don't think I'm really at risk, and so this isn't really for me. Whereas when we look at kind of the indications for who may benefit from taking PrEP, oftentimes people underestimate their risk. And so to kind of bring it all together, what we did is we have a project that currently is trying to really, in all honesty, do both the preparation phase as well as the optimization phase of a trial. So in our AIM-1, we are developing most of the components that we'll be delivering in AIM-2. And AIM-2 is our implementation of 4 different components, 2 at the provider level and 2 at the patient level. And then in AIM-3, what we're doing is we're going to evaluate that implementation process to see what worked, what didn't work, and how we could potentially improve in the future. So here's our conceptual framework. I thought it may be nice to kind of talk through what our different, I'll get into our components in just a second, but kind of talk about what we hope to change what our components are, and then why we thought we would, how we thought we would change those things. So we wanted to, as you can kind of see here in this blue column, our constructs that we wanted to change were knowledge, as I alluded to before. And this is for providers, excuse me. And then also their behavioral capabilities or self-efficacy in prescribing PrEP. And then just kind of also trying to let them know who may be eligible for PrEP. So oftentimes the literature has shown that providers don't feel comfortable talking about PrEP with patients or know who to talk about it with. And so the burden often falls to their patients to bring it up to the provider. And then for patients, what we wanted to do is we wanted to kind of address their risk, so increase or have them have more accurate susceptibility, perceptions of their susceptibility and the benefits of taking PrEP, as well as kind of increasing their knowledge, and also trying to understand what those barriers are and addressing those barriers as well. And so as a result, what we have done is we've developed or are developing, I should say, 4 different components. 2 for providers, so a brief educational module training, as well as a best practice alert. And then for patients, we are developing a risk assessment as well as an educational video. So we've got 4 different factors. So we have a 2 to the 4 factorial experiment, and in each of our different conditions, we have 2 different clinics. So in total, we've got 32 clinics. And as you can see here, this is kind of how our randomization table looks. So kind of take a quick step back just to kind of talk about how we brought together our team. In all honesty, this started off with kind of a partnership with a really close colleague, friend of mine, who we've done a lot of work with regards to, we started off, well, we were in our doctoral program together almost the entire way throughout. And then we kind of have always really worked well together collaboratively, and wanted to take the opportunity to really understand how we can increase PrEP in a pretty large way, if you will. And so when we identified this opportunity and the opportunity to use most, I had attended the training, she had not, but then, we just kind of talked about it, and she was really, in all honesty, like it's really just, we brought together a team that was really, like, for lack of a better word, chill with regards to using most. Like, they really just, everyone was really cool about, using this potentially new framework that maybe they'd either not heard of before or didn't have a lot of experience using before. I think really key to that as well was identifying a biostatistician who was willing to learn more about PrEP, or excuse me, more about most, and like how to analyze data, how to think about the different components and aspects of our study that aren't in the traditional RCT method. And so we really just, brought together, in my opinion, a great team of really collaborative people who are open to learning about most, and then with the addition of Kate in terms of providing that most expertise, it's really been a wonderful team to work with thus far. And so getting more into those components, in order to kind of, develop components that we thought would be most effective, we wanted to do some preliminary data collection. And part of this was in response to reviewers' feedback. They wanted us to create some very specific, so they said they wanted us to create a Detroit-specific educational video for patients. And in all honesty, we didn't really know what that meant. And so we wanted to get feedback from the individuals that would be viewing it and it would be delivered to. And that's where all of this started from. So we've done thus far 2 different things for patients. We've done a quantitative survey as well as focus groups. We broke down our quantitative survey into people who met the PrEP indications so that they would be eligible to kind of talk with their provider about PrEP, as well as just a broad, primary care population as well. So amongst primary care patients, we wanted to get their perspectives as well, because our intention is to deliver all of the patient components to all primary care patients who have an appointment during the study implementation time. So really, we just wanted to make sure that our materials were acceptable to all people that it would be facing. So, in our primary care department, we've got people from patients aged 18 to over 100 years old, all demographic groups. And so just wanted to make sure it was really acceptable by all individuals. And so in our survey, we really asked broad questions about what they would like in a video and what they would like in a risk assessment. And by what they would like, I meant like what types of questions they'd feel comfortable answering, that type of thing. And then in the focus groups, we really talked more specifically about, for example, our script for the patient educational video, and specifically how they would feel about answering certain risk assessment questions. And so, sorry, this is kind of a busy slide, but basically what patients told us is that they didn't really care if it was Detroit specific or not. They wanted a short video that was less than 2 minutes long. They wanted people of all races, ethnicities, skin tones, genders to be represented in the video. We thought, when we were trying to come up with what Detroit specific meant, we thought about all aspects of culture. And so we thought about clothing, we thought about food, we thought about music. And most people said that none of those things really mattered to them if they were in the video or not. Although there were, some people wanted to, so I think probably most Detroit specific, if you will, about this slide is that they wanted to, like, some people wanted to see that it was filmed somewhere in the area where they could recognize. So that's kind of where we landed with that. So just last Thursday, we filmed the video. We had about 7 different individuals who portrayed patients, and 2 providers provide some information at the end of the video. We're still in video production, if you will. So we don't have a final version yet, but we are. The theme of the video basically is PrEP is for me, PrEP is for you, and the video is addressing a lot of the barriers that patients talked about. So cost, access to understanding how effective it is, just some of the different barriers that patients had mentioned before. And then with regards to the risk assessment, we asked people, if they were to be asked, have questions available to them in their, my chart is our patient-facing patient portal. If they were to be able to answer questions that would help them to determine how their risk of getting HIV, how likely they would be to do so. And amongst kind of the general primary care population, basically across the board, there was roughly 70% of people who said they would be somewhat likely or extremely likely to answer those questions, which was heartening for us. And then we also asked them how they would like those responses to be saved, if at all. So if they wanted it just to see for themselves, if they definitely wanted it to be saved so that their provider would see it, or if they could have that option of whether or not they could see their responses and save it and send it on, or just kind of see for themselves and do with it what they will. And most people indicated that they would like that last option to be able to see it, determine if they want to save it for their provider to see, or just kind of, do with it what they will. And then furthermore, with our questions, with our risk assessment, we realized that there's a lot of different ways that people are asking about HIV risk and risk assessment. And so we started off with a Michigan Department of Health and Human Services risk assessment, HIV risk assessment, which is over here on the right-hand side. And as you can see in this kind of third column, there's different scoring for different responses on how people answer. And we weren't really sure what necessity or how that scoring was developed. We tried to look into it, couldn't get any straight answers. And so what we've done is we've kind of created an expanded version of this. We're hoping to validate this kind of as the project goes along, but taking a lot of the same questions, removing some of the assumptions that may be in the questions from the Michigan Department of Health and Human Services one, and including some additional questions that can help us ascertain whether or not somebody's risk may actually be increased or not. And so all of these components, so both this risk assessment and the patient educational video, will be sent to patients in their portal prior to any primary care appointment. So like I said, it's can go, it's most likely going to be going to roughly, I think, like I said, we've got 200,000 people who are seen in primary care a year, so a large population of individuals. And we know that not everyone has a MyChart account or access to viewing those components prior to their appointment. So we're also going to be including iPads in the waiting rooms prior, so that if individuals want to, they can look at the components ahead of their appointment. And what I'll say is what we've been doing, and hopefully we'll be successful doing, is having the components show up in the check-in process online. So when you go to check in for your appointment online, you often have to verify that your insurance hasn't changed, verify your demographics, kind of those standard things that you verify. And then at the end, that's where the either one or two components will show up, depending on which clinic the individual is being seen at for their appointment. And then for our provider components, we again did some preliminary work, not as much as we did with patients, but we've done a couple of focus groups with residents, just to kind of get their perspectives really on the primarily on the training that we've developed, and then more specifically on the best practice alert. So we know that providers from the literature say that they pretty much hate best practice alerts, and that oftentimes they'll confess to just clicking things to get out of them. And so we really wanted to understand how we could develop something that may really try to capture the attention of providers and not be superfluous or not just be rejected immediately. So first, I'll get into the training. We've done a lot of work with the University of South Florida to develop this training with their educational design team. And we are really focusing on trying to, two components really. One is didactic in terms of giving information about PrEP, what it is, how to prescribe it, what labs go along with it. And then at the end of that, we have some interactive components where the providers will get to see 3 different video simulations where they will view a provider and a patient discussing PrEP, and how the provider can see how to talk with different patients about PrEP. So just to kind of give you a brief overview, so just as you can see here, some of our interactive components, we have different knowledge checks throughout, so providers can kind of determine what they've learned, determine who may be eligible for PrEP or who they may want to talk with PrEP about. This is kind of a little bit more of the didactic stuff, so they can click on each of these different boxes to get more information about each of the different types of PrEP. Here's kind of the intro to one of the videos. And then after each video, they have kind of, again, a knowledge check to kind of see if they've absorbed the information from the videos. And then for our best practice alert, this is a little busy, I know, I'm sorry about that, but the idea of what we're trying to do is really make it as easy and as seamless as possible for providers to prescribe PrEP for individuals who may be eligible, or who may meet the indications, I should say. And so what this is going to do, is going to be triggered for any patient who has an ICD-10 code of a sexually transmitted infection in the past 6 months. And those are CDC indicated, or CDC indicators for PrEP eligibility. So providers will be able to see, this is kind of our rough draft of what will happen, but really at first they're just going to see this bottom portion down here, whether or not they will address PrEP with the patient. If they say yes, then they'll get taken to an order set for all of the labs that need to be ordered. And these will be, as you can kind of see here, automatically click yes to order everything. For example, if a provider is seeing somebody who is assigned a male at birth, they could then click down here, do not order a pregnancy test, so that they can make the appropriate orders they need for that individual patient. Then after this, it's not developed yet, but the provider will then be taken to, the orders will be done. Once the patient has the orders, or has the labs completed, the provider will receive an email, automated email back saying all the labs have been complete, review the labs. And if the lab, so we'll have some indicators within that that email saying, like, the individual has to be HIV negative, for example, in order to be prescribed PrEP. And if they meet all those indications, then there'll be a link, I think, in that email that will take them back to the prescribing page where they can then just click and send in the prescription for the medication. So really, this is kind of, like I said, the idea is to make this as seamless as possible for the provider to not have to address kind of those barriers of knowing what the lab orders are, knowing so which individual labs to order, and then kind of making that a step seamless as possible process as possible. So all of our components will be implemented at 32 clinics, like I said, across our health system in both family medicine and internal medicine. And we also have an academic internal medicine department. As I said, there's going to be 2 clinics per condition. And then our main outcome is the number of new prescriptions for PrEP that are written at the clinic level. And so our main outcome is at the clinic level. I've already talked about how the patient components will be delivered prior to a primary care appointment. For our provider training, like I said, we have roughly, it fluctuates, but roughly 180 to 200 primary care providers at any given point. So we're going to have about 100 providers that will be receiving the training. For the best practice alert, over the past year, we had about 20,000 individuals who met the PrEP indications. And by that, I mean who had an STI diagnosis in the last 6 months. Of those individuals who had that diagnosis, about 2,000 then had a primary care appointment within that 6-month time frame. So we're missing about 2,000 people per year in primary care alone who would meet the indications for PrEP. For our follow-up data assessment points, we are hoping to get surveys from 1,200 patients, 180 providers. Like I said, we think it's going to take us about, it depends, 2-ish or so years to meet those numbers for secondary outcomes. Kind of getting a little bit more into those secondary outcomes. So as I said, our main outcome is number of PrEP prescriptions. We're going to be doing some additional surveying of patients and providers after, as I said, to kind of understand what worked and what didn't work. So we're going to do an immediate survey after appointments to understand whether or not the patient actually talked about PrEP with their provider, and then to get some immediate feedback on probably like a 1-question item for each different component, depending on whether or not they receive the patient components. And then we're also going to do a follow-up survey 6 months after the appointment to kind of get some of the longer term outcomes with regards to trust or distrust in the healthcare system, understand if their awareness and willingness to take PrEP has changed, to understand their perceived risk of HIV. And then for providers, we're also going to do a closeout survey at the end of when they've met when the implementation for the intervention components ends. We're going to try to capture provider demographics to try to do some concordance between patients and providers to understand if those who have concordance with regards to race or potentially sexual orientation if those patients are prescribed PrEP more or less, if you will, to understand providers' PrEP knowledge and if that's changed or not, to understand if their intentions to prescribe PrEP have changed, and then also kind of their motivation and behaviors with regards to PrEP. So other data that we're also collecting, because we're in a health system, we are pretty lucky in that we have access to a lot of different data points. So with our educational video as it's being rolled out, we'll be able to understand how many patients actually clicked in my chart to get to that page to see the video itself. We'll also be able to see, for those who have the risk assessment, we'll be able to see that same thing. We'll get to see the number of people who save their responses to send to their provider. And of those people, we'll be able to see the responses as well, so that we can see, how many people may have indicated they may be at some type of risk for HIV. And then we're also going to be asking everyone before they take that risk assessment a 1-question rating their HIV risks to know whether or not that risk changed. And then for the provider training, it's going to be administered through our CME office here. And so we'll be able to ask kind of pre and post questions for those providers to understand if their knowledge has changed, with regards to PrEP and HIV and comfort prescribing PrEP. And then for the best practice alert, each of those points that I talked about, so, the number of people who clicked, yes, I'll talk about PrEP with my patient, we'll get to know. We'll also get to know the people who said no. We'll get to know, actually, honestly, even the provider ID of who said yes and who said no. We'll get to know who ordered PrEP labs and the number of those providers. We'll get to know the number of people who sent in a PrEP prescription. So we'll have access to a lot of different data to understand kind of where the potential sticking points were, or areas or individuals who really were on board or maybe not on board with this. And so here's our planned analyses for our main outcomes we're going to do in ANOVA as we for the factorial design. We've got a number of different secondary outcomes, and so depending on what we have, like I said, a number of different outcomes. So for example, we can do some regressions with regards to the number of HIV tests that were ordered at the patient level, or we can do some moderation and mediation analyses as well. And so, full disclosure, I'm not a biostatistician, so I would defer to the biostatistician to give some more information about that. But we do have a lot of things planned. And then for our AIM-3, to understand kind of those implementation outcomes of what worked and what didn't work with regards to this, we're planning to do semi-structured interviews with both patients and providers and stratify those by providers. So for providers, we're stratifying by those who did prescribe PrEP and those who didn't, to kind of understand again those sticking points or what did work, and then the same for patients. We're stratifying based off of the intervention component. So with that, I will just say thank you to all our collaborators. We have a great team that has really helped us get to this point thus far, and I'll open up for questions. I'll put my contact information here for anyone who would like it.
Wonderful. That was so interesting, Liz. Thank you so much.
Yeah.
To our attendees, please feel free to put some questions in the chat if you have them. I have received a few as well, so I can kick things off, and of course I'll also open it to the room here if we have questions in here too.
I'm gonna stop sharing just so I can see. But
Sure.
I'll back up too, if need be.
I'm wondering if you could speak a little bit to some of the logistics of carrying out your factorial experiment with the EMR and working with EMR coders about turning components off and on.
Yes, so that has been interesting in terms of getting things developed in the EMR. So we have the way that our system is set up, and it may be similar in other systems, I don't know, but we have coders who focus on patient focusing things within the Epic system, and then coders who focus on provider facing components broadly from the Epic standpoint. And so we've had to work with both of those different groups to get the best practice alert developed, as well as kind of developing things within the patient facing side. There's definitely some limitations to what can be done. Our great project manager, Sean, he has been really working on figuring out how we can get that risk assessment mathematically put into to the EMR, because there's literally a space for a one-line calculation, and it cannot do very advanced mathematical calculations. And so we've had to run into kind of figuring out how we can do that. More broadly, there's also truly, I don't even know how many different committees that have to approve everything. It feels like every time I get the approval from one committee, then it's like, oh, we need to now go to this other committee and get their approval. And now we need to go to this other committee and get their approval. And so we are at the point where I think we're jumping through the hoops, and I think the end is in sight, but it's like every time it seems like, oh, but now there's this new place that needs to give us the approval. So that's really been a big learning sticking point for me as well. I think there's being new in the health system when I wrote this grant, and then, I think there's always things that are changing. It's just kind of going along with, making sure we're not stepping on people's toes, not wanting to step on people's toes, but still trying to really keep everyone on top of, okay, we need to move forward because we can't just have it be stuck with this committee for 2 months until they meet again, because that holds everything else up. So it's a sticking point, but we're making progress. Our goal is to have everything turned on in January, for a pilot clinics, 2 clinics. So,
Awesome.
hopefully we'll be able to kind of, we initially were saying September, then October, and now January, but I'm pretty hopeful that January will actually work.
I know that feeling. Good luck. So this was your first R1 and first big proposal using most.
Yeah.
Our question is, what advice would you give to someone else in that same position? There are many of us out there like that.
Yeah, that's a great question. I really think number one would be having a supportive team, getting a team together that is really supportive and both kind of understanding and willing to learn about most. From my experience, I would not have Kate on our team, but I don't think you need to have I know there are some teams that maybe everyone is, or maybe a lot of people are most experts. And I think we've done a fairly decent job thus far of having, people from all sorts of different backgrounds. And that, I think, is a true testament to the strength of our team, is that we're bringing in all these different expertise. And in terms of writing the grant, I think the KISS method is great, because keeping it as simple and as straightforward as possible is best. Like, I literally was looking back at the grant proposal the other day, and I set up, here are the barriers, went into 4 different things, 2 for patients, 2 for providers. This is what we're going to do to address the 4 barriers, 2 for patients, 2 for providers. And so just really laying it out as simply as possible. So because some reviewers may have a more difficult time putting their head around the most framework, the concept of doing a trial in this way, just spelling out what you're doing as simply as possible, I think, in all grant writing, I think is true, but I think especially when you're throwing in this potentially unknown for, framework of how to carry out the experiment. So I think it's really important to just kind of take a step back too. I think, we submitted this twice, so first round, and then we, had to resubmit, and having that time in between really helped when looking at it again, to help identify, oh wait, I thought this was clear, but rereading it now after some time away is, it's not as clear as I initially thought. So, and then getting the feedback from your entire team if possible. I know sometimes that can be difficult, but getting feedback from multiple different people to really understand if it is confusing or what is confusing, and then how to reframe it so that it's maybe less confusing.
May I ask a follow-up question?
Yeah.
Liz, can you talk a little bit about how the reviewers reacted to most?
Yeah, in general, they were really on board with, I don't think the reviewers hadn't heard of most. I think they were excited. That was one of the strengths of the proposal was us using most. I got the feeling that, I could be wrong, I mean, I don't know who the exact reviewers were. I don't think that anyone was an expert in most that reviewed the grant, but I don't think that it was, I've heard of individuals who've had grant reviews that the reviewers just weren't getting the method, and I didn't get that feeling with this.
That's great. It was NIMHD, was it?
Yep, NIMHD.
That's one that we have not seen as many applications of most, so that's really encouraging to hear.
Yeah.
How about your conversations with your PO about everything? Did you use any specific strategies in building that relationship around most specifically?
No, not really. In all honesty, like it was an RFA, and so the first round, the PO, it was a different PO between the first and second round. I think the first round PO retired, and then the new PO came in after getting notice of, or well, getting scores back and kind of thinking that it may have the possibility of being funded. The PO was really really on board. All that they were really concerned about was, kind of wanting us to keep in mind the racial and ethnic disparities and how we were going to address those. And they didn't really have any comments or issues with using most at all.
Great.
Yeah.
So you have some preparation phase and some optimization phase content in the same proposal. Can you say a little bit more about your strategy for doing that, and maybe as you're in the process now, maybe advantages and or disadvantages as you see them of that strategy?
Yeah, that's a great question. So because it's an R01, we've got 5 years, and we got pilot funding to do an initial version of our provider training. That was in its infancy. So in all honesty, I would say we're probably developing 95% of all of the components in this project. There's some benefits to that, having a little bit of time to be able to develop those and to more fully kind of think through and have the money to be able to compensate participants for answering questions and getting that feedback. But it does condense timeline a lot, right? So we've been funded now for just about a year, and I wish, in some ways, we would have been able to implement and start the optimization phase, 3 months ago or sooner. So it's a balance. If I were to do it again, I probably would have liked to have had something more fully developed going into the R01 phase of things, but beggars can't be choosers, right? If you get the money, you have to do what you can do to get the money. So we're at the point now where we can, I feel like more equitably compensate participants for answering questions for the development of things than I would have been able to otherwise. So it's doable. It just makes it more condensed. And I think, we're lucky that we have a large patient population that we can potentially more quickly access and get that information out than maybe individual other instances and other areas where your patient population or your participant population may be smaller, and it may take longer to reach the number of people that you need to.
And you said that reviewers were pretty enthusiastic about most, so they also didn't give you pushback about the incorporation of preparation phase with the optimization work?
That required some grant writing. We didn't necessarily call it out as we were doing the preparation phase. We kind of said we would just be developing some components and doing development. It wasn't apparent that it was going to be preparation phase and then the optimization. It wasn't that clear cut. And so that I think we use some kind of grant writing skills to kind of help with that.
Did you get any pushback about not having an evaluation trial?
No, not at
during
all.
the 5 years? No, not at all. That's great.
Kate has her hand up.
Liz, I enjoyed writing this grant with you and your team a whole lot, and I was wondering if you could talk about our approach to the power and sample size kind of footwork that we did in the grant writing process.
Yes. So there was a couple of meetings where Kate, myself, and the biostatistician sat down and kind of just went into the SAS macro and played around, in all honesty, and to try to see what we could do with the number of clinics that we have, with the patient population that we have. And so we were able to determine that we could have kind of a medium effect size, and it required just some kind of finessing too, and collaboration of talking about like, oh, does this make sense? Can this work? The SAS macro was great because I think it helped me at least to really understand, okay, if we only, let's say we didn't have the 32 clinics and we only wanted to have one clinic per condition, what would that mean for our power? What would that mean for what we'd be able to say? And so that's really why we ended up with the 2 clinics per condition, because we wanted to have a robust enough power to be able to say something meaningful.
I think the other element to that, Liz, is that a strength of your proposal was that you were anchored in a health system. There were a fixed number of clinics. And so it was a little bit of that artwork of saying, here's the potential for what we're doing. And oh, look, we also have power to detect what we think could happen. Like I think you nailed that part. I'm biased, but.
Thanks.
And did you choose an alpha of 0.05 or 0.1? And did you
It was 0.05.
deliberate on 0.05?
Yep.
Did you deliberate about, which of those to go with or others?
I think that if I can remember correctly, I think we maybe played around with that once or twice, but I think really because, as Kate alluded to, the size of our system, we didn't need to, I don't want to say make that concession, but that wasn't something that we needed to look at as closely as, saying, okay, we know we have 32 clinics, so what can we do with that?
Yeah. Can I make another comment?
Yes, please.
I get asked a lot about whether it's possible to optimize components at different, optimize an intervention that would potentially have components at different levels.
Mm-hmm.
And that's what you have here, and I think it's a really beautiful example of that. And I always tell people, in theory, yes, you can do that, but in practice, it's very often complicated to do that. Now, you were fortunate that you were able to do between cluster randomization, which not everybody can do. Some people, for various reasons, have to. Then there's a really complicated and even more complicated nesting structure under those circumstances. But I guess I just want to comment that that's something, and that this is a beautiful study. That's something that's even extra special about it. And I hope that you wave that around when you're presenting it, later at conferences and when you write about it, because, and I will certainly, I really want to keep up with when this gets published, because I will definitely point people toward your study. Because as I said, I get asked that question a lot.
Yeah, we're really fortunate to be in a health system, to have, the structure to be able to do this. One thing that I was kind of also contemplating, but just given my newness in the system, was, thinking about potentially even a 3-level design, and that, we've got patients, we've got providers, and then we have a lot of system policies that may or may not impact one's ability to access PrEP. And I didn't go that far because I was new. I didn't really know even, who to talk to or how to tackle that from a practical, feasible standpoint. But I think, moving forward, that would also be something really, really interesting to consider as well.
Yeah, that would have really complicated things, though, I think.
Yeah.
I think this is a really nice, relatively straightforward example of how you can do this, and I really like it. And also, I loved your conceptual model, and I know Kate had a hand in that because I kind of had Kate's fingerprints on it. I could tell that. But
Thank you.
And I haven't seen in the literature a lot of multi-level conceptual models, and so that's something else that I think is really interesting about this. All right, are you going to publish a protocol paper?
We have, yes.
Yeah, okay, and the conceptual models in it?
Yes, I think so.
Yeah, that's great.
I love showing that off just because I'm a visual person and the color, like I love the colors. I love just kind of being able to look at it that way. Kate was really instrumental in helping think about like how to even visually depict the different levels and how to present that in a way that could be understandable to others. And so, yeah, it's I try to use that as a template now for a lot of my conceptual frameworks.
What was that in your grant proposal?
It was.
Yeah, so everyone listening, I always tell people, reviewers love a good conceptual model. They really, that is always a big strength if you include a well thought out conceptual model in a grant proposal. Reviewers love that.
Liz, I'm trying to remember from your secondary outcomes, do you have outcomes at both the provider and patient level?
We do.
Have you thought much about, incorporating those different outcomes in your choice of an intervention? Are you gonna be using both types of outcomes to pick an optimized intervention?
Yes, I think so. I mean, really from a system standpoint, in terms of like what the leaders here are wanting is, if we're going to be implementing a best practice alert, for example, they want to do something that is, that's going to be not there's less of an appetite for research that's going to come and go. And so if my whole spiel to them has been, we'll be able to tell you if this really is effective and then have the evidence to say, we're going to keep this long term. And so the long answer to your question, Jillian, is yes, we are going to be looking at both provider and patient level outcomes.
Awesome.
That has some interesting implications for decision making, doesn't it?
It sure does,
Yeah.
yeah, so we'll just extend our comment about it being beautiful and interesting and something we can point people to.
Yeah.
Well, I just want to also give a quick shout out. I know we're almost at time, but Jeremy Toney is here with us. He's project coordinator in our study, and he's a great advocate for HIV prevention in our community. So I just wanted to give him a quick shout out too.
Wonderful. Hi and welcome.
Yes.
And thank you so much, Liz. This was really so interesting and it contains a lot of really useful wisdom too, I think, based on your experience. Thanks again to all of our attendees for being here today.
Thanks, everyone. If you'd like my contact information, I'll share my slides and you can access it there.
Wonderful. Thanks again,
Liz.
Liz.
Thanks.
Thank you.